title Advantage Vitamin D and Other Bone Markers. We've clubbed bone markers together with vitamin D. And this vitamin D becomes so very important, especially in our lives, in female, especially after the age of 30, 35. And how important it is, let's take a look at it. Alright, so let's understand this concept. So both D2 and D3 are precursors, provitamins, and are converted to the same active metabolites which are responsible for the absorption of calcium. And you know how important this is, especially to us females. There's a quote here, The Science and Practice of Pharmacy, 19th edition. It says by Lance Anderson, as far as your body is concerned, the two different types of vitamin D are identical. You can see the structure below. Okay, let's go ahead. So the metabolism, it's quite simple. You've got 7-dehydroxy cholesterol in the presence of sunlight, converted to cholecalciferol, that's vitamin D3. In the liver, it is converted to calcidiol, 25-OH-D3, and finally to the kidney where you will get calcitriol. So effects of calcitriol: intestines, increase calcium absorption, increase phosphorus absorption, decrease magnesium absorption. Parathyroid gland, which is under the thyroid, and we'll take a look at it next time, increase mineralization indirectly via the calcium phosphorus in the intestinal lumen. I better take my glasses out. I feel it better. At high doses, increase osteoclastic bone. In kidneys, auto-regulated to calcitriol production. So the bottom says years of research have led to an in-depth understanding of the metabolism of D, with the moniker of vitamins is not correct in the classic sense. In reality, vitamin D is a prohormone that has many effects. And here you can see how important the sun is in the conversion. And the best time to sit in the sunlight is between 11 and 2 o'clock in the afternoon. This is what helps the vitamin D metabolism. Keep that in mind, between 11 and 2. This is how it converts. Vitamin D ingested from food and other supplements, exogenous. Vitamin, that was D2, sorry, then this is D3, cholecalciferol, synthesized in the body, exposure of skin to sunlight, endogenous. While so D2 is exogenous. Both converted to 25-hydroxy vitamin D. It's an inactive precursor. Measured by lab tests, total 25-hydroxy vitamin D. D2 and D3 may be differential, and is finally converted to 125-dihydroxy vitamin D or 125-OH-D, inactive hormone, measured by lab tests. So we were previously measuring D3, and we were having problems with the kit. Eventually, when we turned it over and got into vitamin D, we hit success. So here you go, the body itself makes vitamin D when it's exposed to sun. So keep that in mind. I think you all know. Cheese, butter, margarine, fortified milk, fish and fortified cereals are good sources of vitamin D. There's a quote from the draft prepared by the task force and reviewed successfully by the Endocrine Clinical Guidelines Subcommittee, Clinical Affairs Core Committee, and co-sponsoring associations. So you'll find in my lectures a lot of these things are there, especially when we take a look at the cardiac functions, cardiac markers, TROP-T, and so on. This was posted by the Endocrine Society website for member review. All recommendations were taken into account. This was May 2011. acceptance and published online June 2011. In the USA, they lay a lot of stress on these little bits. Quote from a draft prepared by the task force and reviewed successfully by the Endocrine Clinical Guidelines Subcommittee, Clinical Affairs, Core Committee, and co-sponsoring associations. This was posted on the Endocrine Society website for member review. All recommendations were taken into account. This was May 2011. Acceptance and published online 2011. The recommendation is, we recommend using serum circulating 25-OHD. Please keep this in mind. Measured by reliable assay to evaluate the status of vitamin D in patients who are at risk of vitamin D deficiency. Vitamin D deficiency is defined as 25-OHD below 20 nanogram per ml. Between 21 and 29, vitamin D is insufficient. So you can see the marker below, right? So red lines up to 20, between 20 and 40, still a little low, and the blue lines extending 40, about 35, 40 onwards. Keep this in mind. Somebody's coming. So, just a moment, guys. Somebody's checking in. Somebody in or out? Shili. Come on, Shili, you're late. All right. No. This was the last. This was it. Huh? आगे जाके देखो पहले again. All right, now after that. All right, so the concentration, a part to remember, keep it in mind. Concentration of 25-OHD is almost full of the 125-OHD, 2D. And the half-life of 25-OHD is much longer, implying that its concentration is more stable. And we are going to see that. Evidence 25-OHD is the major circulating vitamin D. Half-life is longer and it's best indicator of vitamin D status. The half-life of 125-OHD, that's D3, is approximately 4 hours and circulates 1,000 times lower than 25-OHD, vitamin D. And here the blood level is tightly regulated by PTH, that's your parathyroid hormone, calcium and phosphate. 125-OH2 D3 does not reflect D reserves, and therefore measuring 125-OH2 D3 is not useful in monitoring vitamin D status. So please keep this in mind, and we'll see how well it stores. This is frequently either normal or elevated in vitamin D deficiency due to hyperparathyroidism. So thyroid again playing a very important role in this. Thus 125-OH2D33 is truly not reflective of vitamin D status. It's useful in acquired and inherited disorders and the metabolism of phosphates losing disorders, including kidney, rickets, granuloma, sarcoidosis, etc. So you need more vitamin D as you grow older. Just ignore it. So until the age of 50, you got up to 200 IU, you're okay. Between 51 and 70, 400 IU. And over the age of 70, you need at least 600 IU. So multivitamins typically provide 400 IU of vitamin D. 1 cup of vitamin D, fortified milk or juice provides 50 IU. So all these sources are rich sources of vitamin D. And things have changed here of how much you need as you grow older. You can see the good source is the fish, you've got milk, you've got eggs, all right, and cereal. There's a 2007 paper. See the difference in 2007 and 2011. Vitamin D status and metabolism from the Journal of Bone and Mineral Research, volume is there, published online 2007. Vitamin D status and metabolism is characterized by many circulating metabolites. Serum 25-OHD, 1,25-dihydroxy vitamin D, and 24,25-dihydroxy-D have been assessed in many epidemiological studies. So like you can see the different fractions, but the most important is D. The 2007 thinking. The first two metabolites are of major interest for the assessment of vitamin D status and evaluation of vitamin D metabolism. The major circulating metabolite is 25-OHD, whereas active metabolite is 125-OHD, that's your D3, is responsible for the most actions of vitamin D. Decrease of serum 25-OHD vitamin D is decreased by thyroid hormone, anticonvulsants, cholestyramine and orlistat, but otherwise stable. The concentration of 125-OHD D3 is directly influenced by serum calcium and phosphate, calcium intake and immobility. So that's the reason why they say the more active you are, the more you walk around, you're going to be in good positions, all right? Increase. Serum 125-OHD D3 is increased by PTH and PTH related peptides. Prolactin, estradiol, testosterone, prostaglandins and biophosphates. And decreased by corticosteroids, phosphatoin, ketoconazole, heparin and thiazides. So stimulation by other hormones and negative feedback loops clarify it is a hormone. Somebody coming in again? Amina. Alright, let's go back to the lecture. This is done, right? Yeah. Before that, what did you have? Alright, okay. So now we take a look at how PTH plays a role. So low concentration of calcium in blood, remember this, right? Release of parathyroid hormone. Now what does this parathyroid hormone does? Acts on the bone, efflux of calcium from bone, takes it away. Then it acts on the kidney, decrease loss of urine calcium. Then you've got enhanced absorption of calcium from intestine. So it works on the bones, it works on the kidneys, and it works on the intestine. And eventually you'll land up with increased concentration of calcium in the blood. So it is inverse where vitamin D concentration is concerned. This is the way PTH works. So when to access 25-OHD? Instances vary and note of interest. Old patients with hip fractures are known to have low levels of 125-D3. This was partly caused by decreased renal function, but also to severe vitamin D deficiency. This is because the synthesis of D3 becomes substrate dependent, and this can be concluded from the positive correlation between serum 25-OHD-D and 1,2-D3 in these patients. This indicates that serum vitamin D is a measurement of choice to diagnose vitamin D deficiency and to assess vitamin D status. So your D3 depends on quite a few functions, your renal function, your bone, the exercise and so on. So the most stable compound right here is vitamin D, 25-OH-D. So you can take a look here, you've got hip fractures, because somebody falling down fractured the bone, and below that you've got the vitamin D tablets. So this advantage of D3, why is it not preferred? On the other side, serum, that's your D3, is not suitable to assess vitamin D status because it is kept within reference range limits as long as possible by hormonal mechanisms, especially PTS for stimulation and serum calcium and phosphate suppression. So see, it's dependent on quite a few things, your vitamin D3, whilst your vitamin D is a very stable compound. And you've got the picture here, and you can see calcium regulation and how it is affected by bones, by kidney and intestine. What happens is this, keep in mind, 125 OHD circulates 1000 times lower than vitamin D. As patients become deficient in vitamin D, there is a decrease in intestinal calcium absorption, which lowers ionized calcium transiently. As a result of this, PTH gets into the act. PTH regulates calcium metabolism by increasing tubular reabsorption of calcium from kidney, increasing mobilization of calcium from skeleton, and by increasing renal production of 125 OHD. So see how one is dependent on the other. So the first fact is vitamin D circulates 1000 times lower than 25. That's your D3 circulating 1000 times lower than vitamin D. So as the patient becomes deficient in vitamin D, what happens? It has to pull from somewhere, right? There is a decrease in intestinal calcium absorption, which lowers the ionized calcium transiently. So temporarily it's done that. As a result of this, the PTH gets into the act. The body regulates that calcium is low. Now what do? PTH regulates calcium metabolism by increasing tubular reabsorption of calcium from kidney. Right? Keep this in mind. Increasing metabolism of calcium from skeleton and by increasing renal production of 125 OHD. Thus, a patient who is really vitamin D deficient will show normal to elevated 125 OHD. Thus, this makes the assay of 125 OHD, that's your D3, measure useless. It is useful in cases of several inherited and acquired disorders of calcium metabolism, as they are related to the alterations in renal and extrarenal production of 125 OHD. So, really speaking, D3 is not a stable indicator of the vitamin D deficiency. Here we go. See how PTH acts. Intermittent versus continuous decrease in plasma levels of PTH. So you can see you've got the calciumetric compound, how it goes up and down over the days. So this is the effect of your PTH on vitamin D. See what it does. It actually compromises your vitamin D. So when to access vitamin D? That's the question. Vitamin D should be assessed in persons at risk of vitamin D deficiency or insufficiency, including nutritional causes, malabsorption like celiac disease, or the bowel problems, and patients with renal disease. Example, nephrotic syndrome, when it is lost in the urine. Older persons and patients with osteoporosis are at risk, as well as small children and pregnant women. Interesting data is available in various ethnic groups and countries. So you then take a look at you got a pregnant woman on the left, and take a look at the bones. Right? It is just network, and you can see that it's not a very healthy picture. So advantage vitamin D, serum 25 OHD should not be considered in isolation, but should be accompanied by clinical information and by serum calcium phosphate, albumin, creatinine, and alkaline phosphatase levels. When feasible, a 24-hour urine calcium excretion. A little cumbersome at times, but necessary. Vitamin D is relatively stable and not directly influenced by diet, example calcium intake, and lifestyle, example mobility. As against vitamin D3 is not a very stable compound. And again, you've got the same little picture below. You've got the sunlight, and you've got the conversion to vitamin D. All right. It's the same vitamin D, liver, kidney, 125 OHD, that's your calcium, muscles, bone health. So it regulates blood pressure, insulin production, heart diseases, and so on. Your 125 OHD regulates of immune, fructose, diabetes type 1, and so on, and regulation of cell growth, cancer prevention, and so on. So it's got many functions. We'll take a look at it. So other advantages, a good life, bone health, cardiovascular, cancers, TB, MS protection. All right. The role of D3 has been used as a common assay. Time to switch to total vitamin D assay on our Cobas system. Of course, this is Roche promoting the machine and the system. Calcitriol is also called 125-dihydroxycalciferol or 125-dihydroxyvitamin D3 is hormonally active form of vitamin D with 3 hydroxyl groups. It's abbreviated the same way. It increases the level of calcium in the blood by 1, increasing the uptake of calcium from the gut in the blood, decreasing the transfer of calcium from blood to the urine by kidney, and increasing the release of calcium into the blood from bone. So this is the way it acts, and you can see why it is a little unstable. Adverse reactions with D3. The main adverse drug reaction associated with calcitriol therapy is hypercalcemia. So here you have calcium going up abnormally. Early symptoms include nausea, vomiting, constipation, anorexia, apathy, headache, thirst, sweating, and polyuria. I think you know the meanings, right? Compared to other vitamin D compounds in clinical use, the cholecalciferol, ergocalciferol, calcitriol has a higher risk of inducing hypercalcemia. However, such episodes may be shorter and easier to treat due to its relatively short half-life. Significance in the body. Vitamin D promotes intestinal calcium absorption, bone matrix mineralization, and normal muscle function. And you saw what that bone looks like if it's not there in sufficient amounts. It also regulates absorption of phosphorus and suppresses PTH release from the parathyroid gland. Deficiency of vitamin D has been associated with increased risk of decreased bone mineral density, falls, fractures, secondary hyperparathyroidism, myopathy, osteomalacia. Rickets may also be seen in children. Deficiency of vitamin D may be associated with increased risk of cancer, decreased immune function, cardiovascular disease, and diabetes. So it's got a lot of other markers to tell you that your vitamin D may be down. Low and high vitamin D. A low serum 25 OHD is usually accompanied by increase of PTH, so it is inversely proportional, but the latter may be in the normal range. On the other hand, immobility can lead to serum PTH, lower serum PTH, even in case of vitamin D deficiency. Another reason to measure 25 OHD is hypercalcemic patients when there is a suspicion of vitamin D intoxication. This may occur with over-the-counter drugs, fortification errors, and too high doses for a prolonged period. So you have to be careful that you cannot have too much or too little of vitamin D. And this has come from the Journal of the Bone and Mineral Research. Okay. Here you go. I told you what is normal and what is abnormal. See the comparison between vitamin D and D3. You see why vitamin D is more stable. Half-life. Total vitamin D is 1 to 2 days. D3 is 4 hours. Measures, total vitamin D measures D2 and D3. D3 only measures D3, that kissed. Circulation time higher on the D, lower on the D3. Regulated by sunlight, food, fat. D3 is regulated by PTH, calcium phosphate. D reserve reflection, yes. D3, no. Properties, that's your vitamin D, substrate, hormone dependent. 25 OHD is not, therefore beneficial. D3 is dependent on substrate. Renal function dependent, vitamin D is not, D3 is. Suitable to measure, yes. Don't prefer D3, no. Stability, yes. Less stable, D3. So this is a comparison between the two, and that is the reason why we like to go with vitamin D. We have quite a few doctors in our lab, from our lab, measuring D3. So vitamin D deficiency from the perspective of pediatric, orthopedic and point of view. Vitamin D deficiency is a clinical entity that can affect all children and should be looked for in all children with musculoskeletal symptoms. The child at risk for rickets is now white, breastfed, protected from the sun and obese. Look at the characteristics. Vitamin D deficiency can present as typical muscular pain, pathological fractures or slipped upper femoral epicycles. Obesity is linked with lower vitamin D levels. However, in pediatric population, this does not necessarily equal clinical disorders. Children with low vitamin D present with higher incidence of fractures from normal activities. Vitamin D levels need to be assessed before any form of orthopedic surgery, as it can affect growth both in diaphysis and of the bone, maturation of the bone and growth plate. So here you can see the obese child, you've got a child with rickets, you've got a child with a fracture, you've got a child which maybe even a poor child roaming around somewhere, and you've got somebody looking up to the sun and enjoying it, and you've got a family that enjoys the health and enjoys drinking milk together. What is advised? Children should be allowed to play outside. Sun protection will be needed, so glasses, you can see. SPF of at least 15 to 30 needed, sun protection. Children below 6 months should not have direct exposure. Everyone needs vitamin D, and this can be had by drinking at least 1000 ml of milk fortified with vitamin D. Breastfed infants will also need vitamin D supplements, as well as older children and teenagers. So this is what is advised to keep your vitamin D healthy, especially in a child. Now this is a recommended dosages, but you and I don't go by it. You can see what is needed. You got 0 to 6 months, 6 to 12 months, and the pediatrician will tell you how much is needed and from what, and what limits can be tolerated. We leave this on for some time. Take a look at it. So between 0 to 6 and 6 to 12, you got about 400 IU needed. From 1 to 3, 4 to 18, 19 to 70, you got about 600 IU needed. Over the age of 70, you need 800 IU. And the lady is pregnant, about 600 will do. Lactation, she's feeding a child, 600 IU. So this is your daily minimum requirement. So then you've got vitamin D and pregnancy. A woman needs vitamin D to maintain proper levels of calcium and phosphorus, which help build her baby's bones and teeth. A vitamin D deficiency during pregnancy can cause growth retardation and skeletal deformities. It may also have an impact on birth weight. If she is lacking vitamin D during pregnancy, her baby may be short on vitamin at birth. This can put her at risk of rickets, which may lead to fractures and deformities, abnormal bone growth, and delayed physical development, and the results can be lasting for a long time. Researchers believe that a vitamin D deficiency during pregnancy can affect bone development and immune function from birth throughout childhood. So the lady who is pregnant is monitored for vitamin D, and proper medication or vitamin supplements, etc. is given to her. Complications of deficiency, and this is heartbreaking. A deficiency of vitamin D can also be linked to a greater risk of pregnancy complications, including preeclampsia and higher likelihood of expectant mom to need a C-section. So eclampsia is a sort of cramping conditions in a woman that can lead to proteins in urine, blood pressure, and she may need to get rid of the baby by way of a C-section. They may not wait for her to have a normal baby the normal way. Vitamin D has been the topic of much research in recent years. Researchers are studying vitamin D roles in preventing a number of diseases. These include autoimmune diseases, type 1 diabetes, multiple sclerosis, and rheumatoid arthritis. Osteoarthritic cancers, cancers is different, special colon cancer, gum disease, and high blood pressure. I hope you all have the meanings of these. Type 1 diabetes, that's what comes in from childhood. Multiple sclerosis and rheumatoid arthritis, and so on. How much vitamin D does a woman need in pregnancy? Again, they are quoting, National Academy of Sciences currently recommends that the pregnant woman gets 200 IU per day of vitamin D each day if they are not exposed to adequate sunlight. Many experts believe this amount isn't nearly enough, and the National Academy of Sciences is reviewing its guidelines on vitamin D, so they may change. Bruce Hollis, a professor of pediatric at Medical University of South Carolina, who has researched vitamin D, says, I recommend that the pregnant woman supplements 4,000 IU of vitamin a day, and I recommend that lactating women should take a supplement of 6,000 daily. Where's Joy? Okay. He's there. So vitamin D and diabetes. Evidence has suggested that vitamin D affects beta cells directly by rendering them more resistant to types of cellular stress encountered in type 1 and type 2. Evidence has suggested that vitamin D affects beta cells directly by rendering them more resistant to the types of cellular stress encountered in type 1 and type 2. This review evaluates the role of vitamin D signaling in the pathogenesis of type 1 and type 2, with special emphasis on effects of vitamin D on pancreatic beta cells. So it has an effect on the beta cells of the pancreas, especially with type 1 and type 2 diabetes. Vitamin D and cancer. This comes from the Department of Microbiology, Institute of Science. This is an Indian study. What do you want? That's abstract. Vitamin D, a fat-soluble prohormone, is synthesized in response to sunlight. Experimental evidence suggests that the vitamin D may reduce the risk of cancer through regulation of cellular proliferation and differentiation, as well as inhibition of angiogenesis. These anti-cancer properties have been attributed primarily to 1,25-dihydroxyvitamin D, that's your calcitriol, the hormone form of vitamin D. Extensive research has shown that the cells, including cancer cells, express specific receptors, VDRs, for 1,25-dihydroxy-D. When bound to VDR, 1,25-dihydroxy-D regulates more than 60% genes that exert pro-differentiating, anti-proliferative, and anti-metastatic cells of this effect of the cells, including effects on cell cycle. So here, evidently, your vitamin D has an effect on cancer cells. Alright, so here we go, vitamin D and cancer. Can it stop the disease spread? That is what we are asking. And if you have enough level, sufficient level of vitamin D, it can be controlled. vitamin D and cancer continued. The amount of exposure to sun has been found to correlate inversely with cancer mortality and survival in numerous epidemiological studies. An increased relationship between solar ultraviolet UVB exposure and non-skin cancer mortality have long been reported. Several ecological studies suggest that the sunlight may protect against prostate, colon, rectal, female breast, and ovarian cancers, all diseases that contribute to substantially higher proportion of cancer mortality in the Western industrialized world. So you can see that it has a good effect on the systems of our body. We are continuing. Some analytical studies also suggest a protective association between circulating vitamin D in blood, which is largely derived from sunlight, or dietary vitamin D. Paracalcitriol is, as an analog, is effective as 125 dihydroxy vitamin D in transcavating the prostatic VDR and in inhibiting the growth of prostate cancer cell lines and primary culture of prostate cancer cells in vitro. Promising preclinical evaluation of calcitriol and analogs have appeared in prostate cancer animal models. Its role in immunology. Vitamin D receptor is found in significant concentrations in T lymphocyte and macrophage populations. Highest present in immature immune cells of the thymus and mature CD8 T lymphocytes. The significant role of vitamin D compounds as selective immunosuppressants to either prevent or markedly suppress animal models of autoimmune diseases. 125 OHD, that's your D3, can suppress experimental autoimmune encephalomyelitis, rheumatoid arthritis, SLE, diabetes type 1, and inflammatory bowel disease. So it plays a lot of role in immunology also. Okay, then this is the way it 125, that's your D3, how it affects your different types of cells. So summary list of bone conformation markers is as follows. So these are bone markers: serum total alkaline phosphatase, serum bone specific alkaline phosphatase, serum also osteocalcin, serum type 1 pro-collagen, that's your C-terminal peptide, okay. It's also known as PNPP. Other bone markers besides vitamin D. And these are the markers that are found in urine. You got urine hydroxyproline, you got pyridinoline, and so all, you can take a look at it over here. Urinary collagen type 1 cross-linked nucleotide peptides, urinary serum collagen type 1 cross-linked C-terpeptides, bone sialoprotein, tartrate resistant acid phosphatase. Just keep these in mind. You may not have heard of it, or today you are hearing of it. So these are also the markers usually found in urine. Okay, the general list of bone metastasis screening for bone markers and assays. So this is slightly a little hazy. So you've got bone formation markers, which you can see. They are in number, huh? No. Then you've got bone reabsorptive markers. You've got markers of cytokine excess. You've got screening.
Bone alkaline phosphatase.
Bone alkaline phosphatase and thiopeptide. This has become a little hazy.
Vitamin
Markers of malignancy, you've got PTH
in blood.
and so on. And you've got vitamin D metabolism markers up there. Let me see if I can get a clear picture onto you afterwards. So assays are calcium, phosphorus, alkaline phosphatase are assayed on the chemistry and machines using various principles of colorimetry, spectrometry, and kinetics. Vitamin D, PTH, beta cross labs, and P1NO, mid osteocalcin can be assayed using CLIA. Advantage vitamin D. So vitamin D is in total is based on a completely new assay design, including a fully automated pre-treatment procedure for the quantitative determination of 25 hydroxyvitamin D. The results are standardized again LCMS MS and traceable to NIST SRM. These are all your controls. LCMS MS is the gold standard for estimation of vitamin D total. So here you've got the passing Bablock equation, and you can see how well, of course we're talking in terms of Cobalt, you've got Alexis vitamin D systems, and you've got vitamin D LCMS MS. So this is your you can see it travels, it is on the line and it works very well. UV bits. So ending, a quote from Michael Holick from this paper: vitamin D status, measurement, interpretation and clinical applications. Vitamin D, the sunshine vitamin, is now recognized not only for its importance in promoting bone health in children and adults, but also for other benefits, including risk of chronic diseases such as autoimmune, common cancers and cardiovascular diseases. Michael Holick is a pioneer researcher of vitamin D. And that's a thank you. Okay. Some refresher for your bone, guys. I'm not going to too many details, but it's given you a brief idea of how important vitamin D is. You can keep it in mind. So when your doctor tells you need a vitamin D, you should have it done. Especially if you're a diabetic, you should have it done regularly. Any other question? Have you understood, you guys? At least you've got a brief idea of how important this vitamin D is. Hello? Everybody's gone to sleep, is it?
No, ma'am.
Ma'am, firstly, sorry.
Sorry.
Tell me.
No, it's okay, Jyoti, go ahead.
Ma'am, what is this LCMS? These results are standardized.
Yeah, so this is what do you call it? It's a procedure. I'm not getting the name. Electrophoresis, chromatography, what is it? CMS.
Liquid chromatograph, LC?
Yes, it is chromatography, and we'll give it to you in 2 minutes time. LCMS, and this is the gold standard to which we refer to, but CDC in America goes by LCMS. I'm not getting the right name to give you.
Liquid chromatography.
It
Mass,
is-
liquid chromatography.
It is
mass
liquid
spectrometry.
chromatography, mass
Spectrometry.
spectrometry.
Spectrometric.
Yeah.
Okay.
Chemistry techniques that combine the separation
Yeah.
power of liquid chromatography.
Okay.
So you need special instruments for this.
Okay.
And this is the gold standard to which it is compared. And Alexis is the machine for from Cobas, which measures it on clear. So it is compared pretty well.
Thank you.
Anything else?
Ma'am, firstly, a very happy Teachers' Day.
All right, thank you. Thank you.
And I think from your lecture, what I understand is it's always better to test your vitamin D levels
Correct.
before taking supplements. Is it?
Correct. I'll tell you my story. When I turned diabetic, my vitamin D was done and it was low. So doctor told me to take this tablet. So I, like an idiot, took it every day for a month. And when I went in for a checkup, my vitamin D was 100 and something from, I think it was 15 or 20 it was discovered, and she just yelled at me. I said, I'm sorry, I misunderstood the whole thing. I had to take that tablet, which I do today also, one tablet a week. Then eventually it came down, and I keep a 35-40 mg. For
Because
women,
ma'am, I see a lot of people just popping supplements of vitamin
it's
D
toxic.
saying
It
we
is
are
toxic.
low on vitamin
It's
D.
toxic. I'm telling you, it happened to me. I misunderstood what my diabetologist told me. I take one tablet with 6,000 milli
60,000.
Yeah.
Ma'am, 60,000.
Yeah.
Upright,
But,
upright.
yeah. I told you to take that. I've given you the name now.
Ma'am, even I take once a month, one
Yeah.
tablet. Uprise D3, 60,000 K.
So it is important that,
Yeah.
especially for bone health. And then of course she sent me for a bone scan. She said, no, you better do that, blah blah blah. And the report was my left hand, the bones in my left hand were deficient. So she was quite happy. It was okay, we don't need anything else.
Yeah, but always a good idea to get it tested first before you start the supplement.
Yes, timely we have to do it if we are on the tablet.
Tablet.
Yes, yes.
Okay.